So we're really happy you could join us today to talk about the 2024 proposed hospice rule. We've got some wonderful experts here from SimiTree that are ready to assist you and give you some information on what we know is coming down the road. Again, we're going to wait for just a minute for everybody to get in the room and then we'll get started. We have 30 minutes today and a lot of information to cover, so this is going to be a fast-paced webinar. If you do have questions, please feel free to use the Q&A. If we have time at the end of the presentation, we will get to your questions. If we don't, we will respond in an email back out with your questions and answers. We will be sending out the recording of this webinar about 48 to 72 hours after the webinar finishes. So look for that in your email. The handout will be posted in the chat here in just a few minutes. So hold tight for that. With that, I'm Missy Gilliland, the Director of Learning and Development here at SimiTree. We're very excited you could join us today. We're joined by two of our great experts in hospice, and I'm going to turn it over to them to get us started today. So Jordan, I'll kick it over to you to start us off.
Perfect. Thank you, Missy. My name is Jordan Sian, and I am one of the consulting directors here at SimiTree, and looking forward to going over the proposed rule for hospice for fiscal year 2024. So to kick us off, we can take a look at our agenda and what we'll be touching base on today. First, we'll take a look at the rate updates and wage index that are proposed. Next, we'll take a look at the hospice quality reporting programs and updates. And then we'll move into survey and enforcement updates. And then finally, we will end it with hospice telehealth updates that were outlined in the proposed rule. So with that, we can take a look at what the proposed rate updates are for fiscal year 2024. So overall, the proposed rule outlined a 2.8% increase in payments, which comes out to $720 million. So typically right around what we've seen, historically in previous rules. However, there are concerns with, inflation, pharmacy supplies costs, other factors that are increasing the expense side. So, we are seeing, a proposed increase in payments. However, there's other factors that are impacting hospices all across the United States that are offsetting some of their payments. So one thing to look at, and when the final rule comes out, we'll take a look at what that final number is. And with that proposed increase, it is increasing the hospice cap amount to $33,396.55. And from last year, you can see it's an increase from where we are currently with $32,486.92. And the last big item from a rate and financial perspective with the proposed rule is hospices that fail to meet the quality reporting requirements will be penalized with a 2% reduction. So historically, that's been a 4% penalty. So that would be a 2% decrease from what we've seen historically. So we'll see if that stands up when the final rule comes out. And then with that, we can take a look at by service what the updated rates are. So that first line shows your routine home care for days 1 through 60. For our current rates are $200.11.34, and that would increase to $217.74. Then once we get to day 61 and plus, we see that amount drop. So the current rate is $167, and it would increase to $171.86. For continuous home care, the current amount breaks down to $63.42 an hour, and in the updated proposed rule, it would be $65.06 an hour. Moving on to inpatient respite care, the current rate is $492.10, and the proposed rule is $506.34. And then finally, for general inpatient care, the current rate is $1,110.76, and the proposed rule would be $1,142.20. So that is an overall breakdown of what the proposed rule is, and we will see those final numbers when that final rule comes out. One thing to note here is making sure that you're working with your different EMR and vendors to ensure once those updated rates come out that they are loaded into the system correctly so that you are generating accurate revenue. And, you know, from a payment posted perspective, you're calculating the amount that's going to get paid once the final amounts get updated and roll out in fiscal year 2024. And with that, I will transition it over to Maureen to get into the hospice quality reporting program updates.
Hey, thank you, Jordan. I'm Maureen Kelleher. I am a nurse by trade, and I am a senior manager with SimiTree. I've been with them for 3 years out of my 26 years in healthcare. So I'm looking forward to presenting some of this information. The good news is there weren't many changes for hospice this year, just kind of redefining some of the things that came out in 2020, 2022, and last year. So the CMS did all of their reviews, and in the 2022 reviews, they came out with an article that said that many hospices were not providing all 4 levels of care. And when it comes to a quality program, they were looking at the hospices that did not provide all 4 of them were generally hospices that were in the lowest 25% across all fiscal years that they studied. I believe they did 2018 to 2022. So if your hospice is not providing one of these services, if you're looking at your PEPR reports and you're kind of low on the percentage rates, this is an area that you're going to want to start working on and enhance, because this is something they are looking at, and they are looking at it very closely. The top 5 diagnoses for fiscal year 2022 is also something they're looking at. And if you look at these top 5, they're all, with the exception of COPD and heart failure, they are all related to dementia. This is going to be coming back to haunt us at some time in the future, because these are also the patients that have the longest length of stay on hospice. Okay. This is the length of stay that CMS has come out with. This was data that was accessed from the Common Working File in January. And you'll see the average length of stay in 2019 was 77 days. For 2022, it was up to 80. The median, however, has gone down. It recovered from 2021 to 2022, but it's still down. And then the average lifetime length of stay, so not just for one election of hospice, so they've been on multiple hospices over a period of time. They've been on one, they get discharged, they go on another. You can see those days are trending upwards. So this is also going to be an area that they're going to focus on, and we're probably going to see some changes in the next 2 to 5 years for hospice related to this. And then this is just, if you look, the average length of stay by diagnosis, and again, Alzheimer's, dementia, Parkinson's, stroke, and heart disease have the highest average lifetime length of stay. They are just looking at these to see diagnoses. Are hospices bringing patients on too soon? Are they getting the referrals too late? And when you do look at these, you can see like cancer's average lifetime length of stay is 53, but for Alzheimer's, it's 170 days. Again, these are going to impact future rules. Hospice days by level of care. We're still seeing very low utilization of continuous care, of respite, and of GIP. And they're looking at, well, how many hospice days were in these level of care, and then how much did it cost us from a Medicare perspective? But still, routine home care is the primary level of care that patients are getting. They aren't looking at what's causing this. It could be we're just doing a better job of managing symptoms in the home, but we do have these other levels of care we have to provide, and we have to be making sure that we have them, we have contracts in place, and that we're utilizing them for our patients. Next, okay. So update, there were really no new measures in this rule. Hospices are subject to payment reduction in their annual payment update if you fail to comply with the quality requirements. The 2% to 4% penalties, in 2022, they came out with, well, in 2023, they came out with saying that anybody who did not meet the expectations for the quality reporting in 2022 would have a 4% penalty. If that stays the same, or if it goes back down to 2%, we won't know until the final rule comes out. I have a feeling, even though there's a tease there, that they're going to keep it at the 4%, but we'll have to wait till September to find out. There is a fiscal year 2024 compliance checklist that you have to have everything in for your HIS, 90% submission rates, and you have to have them submitted within 30 days. So you still have to complete them on the different date timeframes, but you have to submit them within 30 days of the admission and or discharge. We have seen some hospices that are doing the HIS in their computers in their EMR system, but they're not getting them to Medicare. You have to have a login through the key system. You have to be formatting these HISs, and you have to be submitting them. If you aren't submitting them in your CAHPS reports and in your notifications from CMS, you will see this 4% hit you next year with your payments for if you did not get your 90% in for 2022. Most of the other components of the HQRP requirements are from your claims, so there's nothing you have to do. They're pulling the data from the claims. You have to be looking at your results though to know where you have to work to get to the levels and the percentages and the points that you need so that you have the star ratings on the Care Compare website. Next. These next slides are just what the measures are. These are the hospice quality, the hospice item set questions, and then the information that they're pulling from your claims. This has been in place since the fiscal year 2022, so we're not going to go through all of these. It's just a reminder that these are the items that they're looking for, your CAHPS survey, CAHPS, your claims, and your HIS. Those are the things that are going to impact your reimbursement. The Hospice Care Index captures processes occurring throughout the hospice stay, and it's between admission and discharge. It is a single measure comprising of 10 indicators. So they'll look at all 10 indicators, and then they give you a summary number of those. It monitors all 10 indicators, and it collectively summarizes these indicators and represent different aspects of hospice services and provide a more comprehensive reflection. If you haven't seen your numbers, I advise you to go look at Care Compare, go into Keys, look at your CAHPS reports and see where you're standing compared to your state and the national numbers. And these are the indicators. I think the next slide has some more indicators on it. Yep. Visits within the last days of life. This is also coming from your claims. They're looking at 3 days, the last 3 days of patient services on hospice when patients pass. So day 1 is the date of death. Day 2 is the day prior. Day 3 is 2 days prior. Any visits that happen after the time of death of the patient do not count towards this measure. And it is measuring registered nurse and social workers on at least 2 out of the 3 final days. If you haven't started to work on a system or a trigger to get your nurse and your social worker out in these last 3 days, it's important to start working on that because this is impacting your quality scores. Next. Our lovely frightening hope instrument that we're waiting to see, it has gone through the beta testing. They have collected data and additional information and ways to change the form. They completed the testing last October, so now they're pulling it all together. to kind of refine and support the final draft items and come out with when they want hospices to start using this. From what we can see so far, it's going to be just like an OASIS type, where it's going to be done on admission. It's going to be done in different parts of the benefit for hospice patients, and it's going to be a collective outcomes driven assessment for hospice to start using. And once they do come out with it, you're going to have to make sure you're working with your EMR vendor to make sure they have it in your EMR systems, and that you're training your staff on how to use it. Can't wait to see what the final instrument actually looks like. So they're still testing and revising. They're going to use some field tests to create a final version that should be taking place this year. And they're hoping to provide more information regarding these testing results on the HQRP website. They're saying late spring of 2023. I'll be happy if it's late spring 2023, but it could also mean that if they get all this out and they want to implement it, we could see this show up in the final rule for 2024. And these are websites where you can get more information on the HOPE assessments and the updates. They also, in the 2023 final rule, they did come up with some questions they were asking hospices. They did get all the results. They developed a committee to look at some of the results of those questions to help with health equity. They convened by the panel that they created was convened by a contractor in fall of 2022, and they're hoping to have a summary of the final recommendations available sometime this year. They just kind of got together with some of the items that answered. I believe they had 6 or 8 questions on the fiscal year final rule for hospices to comment on. They have compiled all those. They put together this team, and we'll have to wait to see what the recommendations are. And then if Medicare moves forward with making the recommendations requirements or just suggestions, we'll see. CMS sees value in adding social determinants of health data items in the standardized patient assessment instrument. So we are going to see social determinants of health hit the HOPE tool. We're going to see it involved in all different healthcare settings throughout the continuum of care for patients, not just in home health or one sector. They're actually looking at even adding it to requirements for primary care. CAHPS surveys. No changes to the CAHPS survey itself right now. However, they did do an experiment with 56 hospices in a web mail mode for this, for the survey that, traditionally is the 47 to 52 question paper survey that comes in an envelope that doesn't say it's from hospice, and very low response rates. What they found was the response rates really didn't make a difference what mode it was in, as far as what they were seeing in the 56 hospices that they tested this out in. What they did find was that if patients were mailed the survey and then had a follow-up phone call to remind them to fill it out, they did have a bump up from about 35% to 45%. The responses for the web mail mode were better response rates if the people they were sending them to had email addresses. So if they mailed them the information about going online and filling out the survey, they didn't have as good of a response rate. But if they emailed the link to the survey, they had a better percentage, slightly better. Also, the response rates to the mail-only administration of the revised and current survey were similar. hardly a difference. The mailing of a pre-notification letter, however, so they sent out a letter saying you're going to get this information, you're going to get the survey. It actually increased the response rate by 2.4 percentage points. And then extending the amount of time people had to finish it to 49 days from 42 resulted in an increase of 2.5. Okay, some of the changes they did with this web model was and they didn't give details, but they removed one survey item that was confusing and contradictory within the hospice team communication measure. They replaced multi-item getting hospice care training measure with a new one-item summary measure. Addition of a new two-item care preference measure, and simplified the wording to component items in the hospice team communication, getting timely care, and treating family members with respect. Some of those, when you looked at them, it flip-flopped the way they answered it, like 5 was always, and then on the next question, 1 was always. So I think people were filling, when they go all 5s, they didn't realize they were getting it, saying the opposite of what they wanted to say on the survey. So they supposedly fixed those issues. Star ratings are going to, and public reporting is going to continue through 2024. I think we can pretty much say that's going to be around for quite some time. The survey and enforcement procedures, they really didn't. They made some changes on the state operation manual so that if you've looked at the new one, they've realigned where all the focus questions are, and they changed some tags. They removed some of the requirements and they added some new ones. So if you haven't downloaded a copy of the state operations manual from Medicare, I would recommend looking at it. It is a great guide for when you're going through survey. They did do the TEP group. It was convened by a contractor, providing feedback on the special focus program that they want to do for poor performers. So this is moving forward. If you have poor performance on your quality scores and your star ratings, they're going to be looking at you to see whether you need extra help, whether you need increased TEPs. You want to make sure that you are focused on where you're lacking in your quality scores. There's a 30-day call for nominations for this group that was held between July 4th and August 4th of last year. 9 members were selected for this program, representing a diverse range of experience and expertise related to hospice care and quality. The final feedback will be publicly available on the CMS website this month. I didn't see it as of Friday, so I'm hoping maybe this week it's going to come out. And then the only other thing is if you are enrolling physicians, if you hire new physicians and they haven't been enrolled in Medicare during the public health emergency, they made it easier for people to opt back into Medicare if they were working for someone where they could bill Medicare. Some providers opt out. They are trying to now catch up with these physicians who didn't opt in or want to opt back out. So there's an enrollment application that they would need to complete. So this would only impact you if you have new providers who have not been enrolled in Medicare. I think that's it. Do we have time for any questions? We have about 5 minutes, 4 minutes.
Yeah. Did we have any questions from the group? Jordan, Maureen, this was great information to share. Does anybody have any questions for Maureen or Jordan before we wrap up for the day? Feel free to use the Q&A or put your question in the chat.
No. People are, so I think that means they don't have questions.
we have a link to the new manual? So Maureen, I think that was the state issued manual. So don't they find that on their state site?
The state operations manual is, if you just Google search state operations manual, you can find it and you can download it, a copy. It's a PDF file. I can, when we send out the recording, I could probably send that to you, Missy, and we could maybe send it with the recording.
Absolutely, we'll do that. Perfect. And then we also had a question that they read in one of the NHPCO's brief that less than 1,000 provider licenses were not able to comply with the quality data submission. Was this mostly due to late HIS?
It was a lot of late HIS. There were some hospices, like I said, that weren't submitting them at all. They didn't understand that their EMR system didn't submit them automatically, and so they never signed up for keys. So they had them done, but they didn't submit them, and Medicare only cares about the ones they get. So a lot of it was HIS. Some of it was based on claims. You have to make sure that before you submit a claim, all their visit notes are completed and signed, so they attach to your claim. So that you're getting those last 3 days, so you're getting all the 10 HCI components. It's more critical than ever that your claims are complete and accurate before you submit them.
Perfect. And then we had one last question. Can you elaborate on the physician billing to CMS and not being paid by the hospice?
So that is another full webinar to go through. There is a lot to it. I will say that CGS has an algorithm that helps with physician billing, but if you need some help with it, we certainly can do a one-on-one. We can provide another webinar if that's something you're interested in. Certainly love to talk about physician billing because hospices generally aren't doing it, and they can be. So there is a right way to do it, but you have to know, is it the nurse practitioner, is it doctor, are they the attending, are they not the attending? So it's a whole webinar. There's a lot involved in it.
Excellent. And then we've gotten another question, Maureen. Do you have a medium LOS per episode data rather than the lifetime measure?
Yeah, that was on the slide. It had the medium and it had per episode and then lifetime at the end of that.
Perfect.
iKeys. So just remember that right now, hospice doesn't use iKeys yet. They've been talking about it for 5 years. They haven't updated hospice. We use the key system in hospice, so you have to make sure you go to CMS Net to get your access to that. And but we could add that link to when we send the webinar recording.
Excellent.
Thank you. Need the physician webinar. Okay.
And I just said we will add that to our list. And if that medium isn't on the slide, we'll make sure to follow that up in the when we send out the recording.
Yeah.
And we'll look to get an invite for that physician billing. So look for that to come up here soon. So I really appreciate everybody's time and attention today. As always, Maureen and Jordan's information is up here. Feel free to reach out at any point in time. We love to hear from you. And again, thank you for joining us. Have a wonderful afternoon or morning, wherever you are. And you'll get the recording in an email. It usually comes out about 72 hours after the presentation. So thank you, everyone. Thanks, Maureen.
Thank you.